Hi, in this lecture, we're going to learn more about the dermis. Now, the dermis is the second layer of the skin, and you probably remember that it's connective tissue. In fact, it's dense, irregular connective tissue. You can see that right here. Now, I'm giving you some numbers for thickness. You don't have to memorize those numbers, but just to put it in context, it ranges, half a millimeter to 3 millimeters. And to give you an idea, a new crayon point is about 2 millimeters thick. So we say that the dermis is roughly about 1/8 of an inch thick if you're curious about that. It has your typical cells of connective tissue, has a gel-like matrix with all of those fibers. And remember, since it's dense, irregular connective tissue, those fibers are facing different directions, which means that it's really good at resisting tension from multiple directions. The dermis is your hide. So if you wear leather, you're wearing the hide of an animal, and the dermis is our hide. And as you can see, it's richly supplied with blood vessels. The blood supply to the dermis is just called the cutaneous plexus. Plexus means network. So you can see all these red and blue vessels. The red ones are the arteries. The blue ones are the veins, bringing blood to the dermis and taking it away. So unlike the epidermis, the dermis is vascular. However, they both do have nerve endings, lots of nerve endings. Remember, if you get a paper cut in your epidermis, it still hurts, even though it doesn't bleed. So when we look at the dermis, there's the superficial layer, which is the papillary layer. And papillae or papilla means rounded or nipple-like projection. And you can see those here that I'm outlining in purple. So this layer sticks up. And what happens is, you'll see in a minute, the epidermis, that stratified squamous tissue, is going to layer on top of that, but more in just a minute. The papillary layer tends to be more of that loose areolar or areolar, I'm trying to say it twice. There's two different ways to say it, connective tissue. It has your blood vessels. It's also going to have lymph vessels and sensory neurons. And again, these papillae or papillary layer is going to have these projections that stick up. Now, what happens with that is that the stratified squamous is going to layer on top of that. The organization of these papillae is genetically determined. And so when your epidermis layers on top, that's what's going to give you fingerprints. And if you look at your finger, you'll see those whorls and patterns, and that's from this papillary layer. And I have a picture of that in 1 second. The receptors here, so you're going to learn a couple receptors. There are some receptors called Meissner corpuscles, and these are in the papillary layer. They are encapsulated, so that means they have some cells around them. I always think they look kind of like a Christmas tree light, a Christmas tree bulb. They have this layer around them and then inside it. And they are responsible for light touch. So very light touch, and these are very numerous in your face, your lips, your fingertips, and your external genitalia. Now, if we look at this papillary layer, what I mentioned is you can see that you have these papillae sticking up, and then the epidermis layers on top of that. And so you can see you get these patterns. Let me get a different color really quick so you can see this better. And you can see these grooves, right? These are the grooves from it layering on top of that. And again, they're genetically determined, so we can use fingerprints to identify if someone was there or not. Obviously, the best thing is DNA. But one thing with this whole fingerprint thing is there's lots of these little tiny sweat pores in your fingers, and especially in your hands. And you have lots of sweat glands. And they say that 1 square inch of skin has 635 sweat glands. I'm not going to ask you that number. That's a lot of sweat glands, and you can see the little pores here if you were to look at that in a microscopic view. And so when you touch something, you can leave behind sweat and even a little bit of oil, but you leave a lot of sweat behind. And then when they put that fine dust on it, the dust sticks to it, and that's how you get your pattern, so you can match a fingerprint. And then since they're genetically determined, it is a good tool used in criminal investigations. Now, as far as the, let me go back up here for 1 second. Okay, got my pen. So you've probably heard of dermatitis before. Now, itis means inflammation of, and dermatitis typically happens in the papillary layer, and it can make it very painful and very itchy. It might get a little discolored as you have the inflammation happening. And so there's different things that cause, dermatitis. You can see them here. But what happens is it's just some sort of irritant is typically contacting the dermatitis or in touch with it. Or you can have an allergic one where your immune system is attacking the dermis, the papillary layer. But either way, if you've ever had dermatitis, it doesn't feel very pleasant. And, sometimes it's as simple as just changing your laundry detergent, because that can trigger it in some people as well. They can be very sensitive. And usually you're going to take some sort of cortisone cream, and that's going to help suppress your inflammation as you learn and kind of help with that itchy rash. Now, the other layer of the dermis is the thickest layer of the dermis, and that is the reticular layer, and that's your typical dense, irregular connective tissue. It has bundles of collagen fibers, it has your elastic fibers, but this is where your hair follicles are located, and this is where the sweat gland actually is. The sweat glands, remember, are exocrine glands. And you probably remember they were exocrine glands. So they're going to secrete through a duct onto your skin. You still have blood and lymph vessels, and then the receptors here, you can see this yellow one here is called the Pacinian corpuscle. Now, this is deeper in the skin. It's deeper in the dermis. So it's going to really respond to a little more stimuli. So it's going to work better at picking up stretch and pressure. This is a picture I threw in the PowerPoint that just kind of shows you the papillary versus the reticular layer. So they look different. The reticular, again, dense irregular tissue. You can see all those collagen fibers, those thick fibers. And the papillary layer has more of those rounded space and papillae. So as far as circulation goes, circulation does affect our skin color as well. And red blood cells are red because they have something called hemoglobin. And hemoglobin has a red pigment, which is actually called heme. So the pigment is called heme, and it's on the hemoglobin molecule. And hemoglobin transports oxygen. That's its main job. And red blood cells are just bags of hemoglobin. So any time that cutaneous plexus is going to vasodilate or vasoconstrict, that will control blood flow to your skin. So if you vasodilate, you probably remember from the inflammatory response that more blood flows to the skin, so it looks red. And sometimes the Latin for that is erythema or erythema. You can say it either way. Red is fine for me. So the skin turns a red color or a pink color from vasodilation. Vasoconstriction is going to decrease blood flow to the skin. And so when we're looking at changes in blood flow, we can see the pink-red color, but we can also have like a paleness that can occur or even a cyanosis. Now, first thing, obviously, the lighter your skin is naturally, the easier it is to recognize if someone's suddenly too pale or cyanosis. And, that kind of was a big deal and is a big deal when we're looking at differences in skin color and when you're diagnosing as a clinician or you're checking a patient's signs. You don't have to look at just the skin. You can look inside the mouth, inside the lip. You can look at the gums as well, and that can also help you see some of these changes in color. So if someone looks pale, it's usually a sign of decreased blood flow. So, if you're anemic, you might be more pale. Or if you've ever seen anyone suddenly turn white, like they say, oh, they saw a ghost and turned white as if you saw a ghost. It's usually due to a sudden drop in blood pressure. Lots of things can do that. We'll talk more about that in AP2. But if your blood pressure suddenly drops, there's less blood flow to your face and you're going to look very, very pale. And then often people might look pale right before they pass out because if your blood pressure falls, you fall because the blood's not getting up to your brain. And you may have heard of this called syncope. That's the clinical term for if someone should pass out. And then cyanosis is usually like a purplish or a bluish color. So again, sometimes you'll see it around the lips. You can look inside the lips, on the fingers. It tends to show up in the hands. You can check the nails, the nail bed as well. And so it's usually a dark purple or bluish color, and that's because there's less oxygen in the blood. So this is a sign of what we would call hypoxia. And for whatever reason, there's less oxygen getting to those tissues and there's less oxygen in the blood. So, we typically look at cyanotic and cyanosis if someone has a breathing issue because they're not getting oxygen in and they're not getting it to their tissues. Now, as far as the blood supply, there's a couple things that can happen with damage to this blood supply. Excuse me. So if you have some sort of trauma, then what can happen is you can get a contusion or a bruise. And so that's broken blood vessels. So some kind of trauma, like you bump your arm on something, the blood vessels break, and when they break, they bleed. And when they bleed into your skin, and eventually that's all cleaned up. But what happens is the blood, right? Initially a bruise looks more like blue and purple. That's the color of deoxygenated blood. And then you might notice it turns kind of green and yellow. And that's just showing as the blood is being broken down by your body. Now, decubitus ulcer, known as a bed sore, is a serious concern, especially if you're looking at nursing homes or if you have patients who are unable to move very much. What happens is circulation is restricted, so you don't get blood to the area. Usually it's from pressure, so from laying in one position for too long, it decreases blood flow. And, as you're decreasing blood flow, it's going to start to kill the skin. The tissues are going to become necrotic. And so you have an open ulcer, and then once you have an open wound, you have to worry about infection, and you have to worry about pathogens now getting in because your skin isn't the first line of defense. And these can cause massive infections in the body and even cause a patient to become septic. So it's very, very important that if you're taking care of someone who's immobilized, that you move them around and change their body position so they don't develop these. Another thing about the dermis, if we look at its strength, it's got all those collagen fibers, which does make it very, very strong, but it does have some elastic fibers so that if you pinch your skin or within limits, right, you can stretch it and it returns back to its original shape. One thing that affects this is the water content. So remember, you have cells and interstitial fluid, which is a lot of water. So if you were to pinch your skin, it's a good place to do is the back of your hand. It should, as soon as you let go, return to how it was before you pinched it. If it stays pinched or a little domed, that's a sign of dehydration. So we talk about turgor, and skin turgor reflects hydration level. So if you turgor means the ability to go back, right, to return to its original size. So if there's a loss of turgor, which is what you see here, it's showing severe dehydration. And I mentioned that the skin can stretch and return to its original shape within limits. So you can get stretch marks, and you can see sometimes they look kind of like purplish. Later, they often look white. And so this is just overstretching of the dermis. So unfortunately, it's going to be common if you grow quickly. So a lot of times when you hit puberty and you grow, or if you're pregnant, you'll get stretch marks as well. Another thing to think about clinically is these things called lines of cleavage. So we know that the collagen and the elastic fibers run in certain directions. And if you look at the blue lines here, these represent the direction that the collagen fibers run in the skin. And so surgically, it's better to cut with the grain, right, with the line, instead of going against it or across it. Sometimes you have to cut across. It's just the way that you got to get in there to do the procedure. But often the surgeons are going to try to cut with it instead of across it because it's going to help with the healing and help the wound heal better and leave less of a scar. Now, that subcutaneous layer is not technically part of the integumentary system. It does help, basically holds the skin on or stabilizes the skin. So we're still going to talk about it. It's made up of two types of tissue. You're going to see adipose and areolar connective tissue. Now, the subcutaneous fat, and you can see this down here, that fat is important because it does help insulate us. And you should understand that if you're trying to give a drug to a patient and you're not giving them a pill, if you're trying to deliver it into the blood supply a little faster, there's a couple routes of administration. So there's what's called a sub-Q or subcutaneous injection. These are through hypodermic needles, right? Hypo, below the dermis needle. Or you can do what's called an IM, which is an intramuscular injection. Now, if you got your COVID shot, your COVID vaccine, that was an IM injection that they gave you. And you don't have to memorize all the differences. I would like you to just know that these are two ways of administering medications. That the benefit of the sub-Q is that the patient can give it themselves. So a lot of medications, if the patient's giving like insulin, you can see in purple here, these are common locations where you can give a sub-Q. I don't think anyone's giving it to themselves in their own butt. Usually the belly is a good spot. So it's a little easier for anything the patient has to give. The muscle is really fast because it's so vascular. So sometimes we use IM because it's going to get in your blood faster. So this concludes our lecture on the dermis.